many individuals keep running to the doctor even though there is nothing wrong with them. These individuals may be preoccupied with their health and body, and in some cases the preoccupation may be so excessive that it becomes maladaptive in their daily lives. Soma means body, and the common problem associated with somatic disorders and related symptoms seems to be initially physical disorders. However, there is usually no identifiable physical cause for the condition. DSM-5 lists 5 basic somatic symptoms and related disorders. They are somatic symptom disorder, illness anxiety disorder, psychological factors affecting medical condition, conversion disorder, and factitious disorder. In each, the individual has an excessive and maladaptive preoccupation with the functioning of his her body. In this unit, we will learn the clinical features, causal factors, and treatment for the 5 basic somatic symptoms and related disorders. 6.1 Somatic symptom disorder. Somatic symptom disorder is characterized by one or more somatic symptoms that are either very distressing and/or result in significant disruption of daily life. Refer to the case study mentioned in box 5.1. Rekha easily meets all the DSM-5 diagnostic criteria for somatic symptom disorder. She experienced abdominal pain, nausea, and intermittent loose stools for a period of at least 1 year. Over the period of 1 year, Rekha met many doctors, undergone many physical examinations and tests, and kept a daily record of her symptoms. Her preoccupation with the symptoms was so distressing that she was finding it difficult to perform academically. An important feature of this disorder is that the physical symptoms, such as pain, are real even though the clinicians are unable to find clear physical reasons. There is a new emphasis in DSM-5 on the psychological and behavioral factors such as anxiety, distress, and time or energy devoted to the symptoms that seem to be aggravating the severity and impairment associated with the symptoms. During the time of diagnosis, clinicians have to specify if the somatic complaints predominantly involve pain. Box 6.1. Case study. Somatic symptom disorder. Rekha, a 20-year-old woman, reported severe back pain as a result of a falling down in her bathroom. After examining her, her doctor prescribed her some medicines for the pain. Over a few months, the pain settled. However, Rekha developed abdominal pains, nausea, and intermittent loose stools. She went through a full body checkup, and all her tests came back to normal. She was then referred to a gastroenterologist who conducted endoscopy that also came out to be normal. No cause was found for her abdominal pain, loose stools, and nausea. She was sent back by the doctor, but Rekha went to other doctors and got the tests conducted again. She started maintaining a diary to keep a record of the severity and intensity of her symptoms. She met with many doctors again for the abdominal pain and nausea that would come and go. In one of these visits, while waiting for her appointment, Rekha experienced excessive anxiety and the doctor had to prescribe her anti-anxiety medicine. She informed the doctors that because of her symptoms and anxiety she was finding it difficult to perform in college. Rekha had been experiencing these symptoms for over a period of 1 year now. 175. Somatic symptoms and related disorders. 6.2 Illness anxiety disorder. Illness anxiety disorder, previously known as hypochondriasis, is a condition in which physical symptoms are either not experienced at the present time or are very mild. However, the accompanying anxiety focused on the possibility of developing a serious disease is excessive. Illness anxiety disorder is differentiated from somatic symptom disorder, in that the physical symptom experienced is mild. In case the physical symptoms are severe and are associated with anxiety and distress, the diagnosis would be somatic symptom disorder. 6.2.1 Clinical picture. Refer to box 6.2 for a case study that reflects illness anxiety disorder. There is an overlap between symptoms exhibited by Rekha and Rishi. Both are characterized by fear and anxiety that one has a disease. However, an important difference between them is Rishi was less concerned with specific physical symptoms but was more anxious about the idea that he might be ill. Rishi presents a typical case of illness anxiety disorder. Rishi was preoccupied with having brain cancer, even when the symptoms were either absent or a minor, vague headache. People with illness anxiety disorder show preoccupation with normal bodily functions, example heartbeat, bowel movements, blood pressure, sugar levels, with minor physical problems, example cough, pain, accelerated heartbeat, headaches, joint pains, or with vague and ambiguous physical sensations, examples such as aching veins, my hair hurt, my heart is tired. The mental orientation of the individual keeps them constantly on alert for new symptoms. They show notable preoccupation with digestive and excretory functions. In spite of an inability to give a precise description of their symptoms, many people with the condition would often give detailed description, because they want to help the doctor find a diagnosis, even though there is no real illness. Some keep a detailed chart of their bowel movements, diet, constipation, and related matters. They are likely to be updated with information on medical topics and feel certain that they are suffering from every disease they read or hear about. Many people buy and use over-the-counter medicines. They are not malingering, that is consciously faking symptoms. The care-seeking type of individual with illness anxiety disorder is likely to come to a mental health professional only after several visits to a general physician. This is because for the individual, reassurance from the doctor that he is well, only has a short-term effect. This disease conviction is a common feature of both somatic symptom disorder and illness anxiety disorder. Because of this, their yearly medical costs are much higher than most of the rest of the population. The doctor-patient relation is marked by hostility and conflict, since they generally resist the idea that their problem is psychological than physical. Box 6.2. Case study. Illness anxiety disorder. Rishi is a 45-year-old male engineer presents to a neurologist with multiple internet searches on the topic of cancer. He states that he just knows that he has a brain cancer. When asked how long this concern has bothered him, he says, "For years I have been thinking that I have tumor growing in my head." When asked about relevant symptoms, he is a bit vague, saying, "I get some pain or pressure right here." He points to the left side of his head, but it. 176. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Is not there all the time. Upon asking about his previous visits to doctors, he replies, "I have had some tests done, MRI and CT scan, but the doctors could not find anything." He admits to feeling relieved after the results, but then few weeks later he was restless again. "They must have just missed something, I think I need another MRI." Rishi is anxious and increasingly irritable when the doctor tells him that since he had recently got most of the tests done and there was no need for another MRI scan. Rishi ends the encounter by stating that he will find another doctor who sees my point and will get me what I need. Box 6.3. DSM-5 Criteria for Illness Anxiety Disorder, APA, 2013. A preoccupation with fears of having or acquiring a serious illness. B. Somatic symptoms are not present or, if present, are only mild in intensity. If another medical condition is present, then there is a high risk for developing a medical condition. Example: strong medical history is present. The preoccupation is clearly excessive or disproportionate. C. There is a high level of anxiety about health, and the individual is easily alarmed about personal health status. D. The individual performs excessive health-related behaviors. Example: repeatedly checks his or her body for signs of illness or exhibits maladaptive avoidance. Example: avoids doctor's appointments in hospitals. E. Illness preoccupation has been present for at least 6 months, but the specific illness that is feared may change over that period of time. F. The illness-related preoccupation is not better explained by another mental disorder, such as somatic symptom disorder, generalized anxiety disorder or obsessive-compulsive disorder. Specify whether care-seeking type, medical care including physician visits or undergoing tests and procedures is frequently used. Care-avoidant type, medical care is rarely used. 6.2.2 Statistics: The prevalence of illness anxiety disorder is estimated by the prevalence of DSM-3 and DSM-IV diagnosis of hypochondriasis. 0.1% of the general population is estimated to have illness anxiety disorder, Scarella, Boland and Barcy 2019. Initially, it was believed that this disorder was more common in the older adults, however this does not seem to be the case. The disorder is spread fairly across various phases of adulthood. Anxiety and mood disorders are often comorbid with somatic symptom disorder. As is the case with anxiety disorders, illness anxiety disorder and somatic symptom disorder tend to be chronic. Culture-specific disorders prevalent in India, like Dot syndrome, which is excessive concern about loss of semen during sexual activity, fits with somatic symptom disorders. DOT is associated with vague mix of physical symptoms, including dizziness, weakness, and fatigue. Such culture-bound syndromes, Yap, 1967, are episodic, dramatic, and discrete patterns of behavioral reactions, Lipsedge and Littlewood, 1979. 177. Somatic symptoms and related disorders. 6.2.3 Causal factors. Illness. Anxiety disorder is a disorder of cognition and perception, with emotional contribution. Individuals' past experiences with illness, both in themselves and in others, leads to the development of set of dysfunctional assumptions about the diseases and symptoms that may predispose a person to developing illness. Anxiety disorder. These assumptions are faulty, unduly alarming, and pessimistic. Misinterpretations of bodily sensations play a causal role. It follows the following sequence. Attentional bias. Individuals with hypochondriasis seem to focus excessively on symptoms and have an attentional bias for illness-related information. Owens and others, 2004. They are likely to have biased attention for any illness-related information, event, or image might prove to be a trigger for the activation of dysfunctional assumptions. They are hypervigilant about one's own bodily sensations also. Activation of faulty assumptions. Illness-related information activates the dysfunctional faulty assumptions about illness and health. For example, a person may have dysfunctional belief that bodily changes are usually sign of a serious disease. Being healthy means being completely symptom-free. If you don't go to a doctor right now, it would be too late. You cannot possibly ignore these symptoms, etc. Misperception. Individuals may also misperceive their symptoms as more dangerous than they really are. Research suggests that the individuals believe that their ability to cope with an illness is extremely low. They see themselves as weak and unable to tolerate physical effort, exercise. Physiological changes. Active increased focus on one's body can create arousal and makes the physical sensations seem more intense than they actually are. There might be changes in bowel patterns, sleeping and eating habits, etc. Behavioral responses. The individual then engages in repeated behaviors such as checking, self-examination, taking preventive medications, reading about the illness, etc. These behavioral responses are reinforced, as the person feels relieved, and are thus repeated. This tends to create a vicious cycle in which the individuals have anxiety about illness and symptoms. Box 6.4, Cognitive Theory of Illness. Anxiety disorder. 1. Attentional bias. A person with illness anxiety disorder climbs staircase and finds his heart racing. Others will ignore this. 2. Activation of faulty assumptions. The person misperceives this to be a symptom of hole in his heart. He begins to have thoughts like, if you don't go to a doctor right now, it would be too late. You cannot possibly ignore these symptoms. 3. Physiological changes. Anxiety about developing the illness leads to activation of autonomic nervous system. He starts sweating, heart beats faster, feels a knot in the stomach, etc. It further provides fuel for her, his conviction that he has a hole in his heart. 178. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 4. Behavioral response. He or she reads about all cardiovascular diseases on various internet websites, and chooses to ignore warnings against self-diagnosis mentioned on the health websites. Visits multiple doctors and undergoes several tests. Figure 6.1. Cognitive Behavioral Model for Illness. Anxiety Disorder. Source: semanticscholar.org. An important question to be asked is, what causes individuals to develop this pattern of somatic sensitivity and dysfunctional beliefs? First, evidence suggests that somatic symptom disorders runs in family and may have a modest genetic component. This component may be non-specific, such as tendency to be over-responsive to stress. Hyper-responsivity may combine with the tendency to view negative life events as unpredictable and therefore, to be guarded all the time. Second, individuals who develop this disorder tend to have disproportionate incidence of diseases in their family. These individuals report symptoms that their other family members may have reported at one time. Thus, it is possible that the individual learned to focus anxiety on specific physical conditions and illness. Vulnerability to health illness disorder is usually triggered in the presence of a stressful life event, example death or illness. Finally, there are important interpersonal and social influences. A person with illness anxiety disorder communicates that, "I deserve more of your attention and concern, and you may not legitimately expect me to perform as a healthy person would." Thus, the benefits, secondary reinforcement, of being sick might contribute to the disorder. 6.2.4 Treatment reassurance and education by mental health professionals has been reported to be effective. The important point to be noted is that unlike the reassurances given by friends, family or general physicians, reassurances by mental health professionals is more effective because it is delivered in a more sensitive manner. Therapy with people with illness anxiety disorder is centered around devoting sufficient time to all the concerns of the patient and engaging in the meaning. 179. Somatic symptoms and related disorders. Of the symptoms for the individual. Cognitive behavioral therapy helps these individuals by focusing on identifying and challenging illness-related misinterpretations of physical sensations and on showing them how to create symptoms by focusing attention on certain body areas. This awareness allows individuals to understand that their symptoms were under their control. Psychoeducation also helps individuals to seek fewer reassurances from the patients. It also discourages individuals from relating to significant others on the basis of their physical symptoms alone. They are coached in more appropriate ways of interaction with others that reduces reliance on the sick role, and promotes healthy social and familial adjustment. Check your progress. 1.1. What is somatic symptom disorders? Thank you for listening. Please like and subscribe our channel. 2. Explain the causal factors of illness anxiety disorder. Thank you for listening. Please like and subscribe our channel. 6.3 Conversion disorder, functional neurological symptom disorder. Sigmund Freud popularized the term conversion hysteria, who believed that the anxiety resulting from unconscious conflicts was converted into physical symptoms which allowed individuals to release some anxiety without experiencing it. In DSM-5, conversion disorder is given the subtitle, Functional Neurological Symptom Disorder. Functional neurological symptom refers to symptoms that result in absence of an organic cause. Most conversion symptoms suggest that some kind of neurological disease is affecting the sensory motor systems, but no organic or physical malfunctioning is present. Conversion disorder is one of the most fascinating of all mental disorders. How does one go blind when all visual processes are normal? How does one experience paralysis of limbs when there is no neurological damage? Figure 6.2 illustrates Freud's explanation of conversion disorder. Figure 6.2. Freud's understanding of conversion disorder. Anxiety unconscious conflict. Conversion physical. Symptoms. 180. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 6.3.1 Clinical picture. People with conversion disorder have symptoms of deficits affecting sensory and/or voluntary motor function that may lead one to believe that the person is suffering from a neurological problem. Ruling out medical causes for the symptoms is necessary for making a diagnosis of conversion disorder. Clinician must be able to provide evidence to distinguish between the symptom and recognized neurological medical condition. This is an important criterion to prevent misdiagnosis of a genuine neurological medical condition as conversion disorder. With advanced technology, misdiagnosis of conversion disorder is much lower than was the case previously. Sensory deficits include conversion blindness, such as in the case study. A person might report that he cannot see anything and able to navigate about a room without bumping into objects. Similarly, in conversion deafness, the person would report that he cannot hear anything yet orient appropriately upon hearing his/her name. Thus, there is registration of sensory input, but somehow the input screened from explicit conscious recognition. Other sensory symptoms include anesthesia, loss of sensitivity, hypoesthesia, partial loss of sensitivity, hyperesthesia, excessive sensitivity, analgesia, loss of sensitivity to pain, and paresthesia, exceptional sensations such as tingling, heat. One of the most common motor symptoms is conversion paralysis, in which the person may not be able to walk for most of the time but may be able to walk in emergency situations such as fire where escape may be necessary. Other motor symptoms include tremors, tics, and contractures, rigidity of larger joints. Astasia abasia is a condition in which individual has grotesque disorganized walk, both legs wobbling about in every direction. Speech-related conversion symptoms are aphonia, in which an individual is only able to talk in whispers or hoarse voice. Other conversion symptoms include seizures. Pseudo-seizures resemble epileptic seizures but can fairly well be differentiated. They do not show EEG abnormalities and do not show confusion or loss of memory afterwards. People with conversion seizures rarely injure themselves in falls or lose control over bowels, bladder. There are other wide range of visceral symptoms that are medically unexplained, include lump in the throat, choking sensations, coughing spells, difficulty in breathing, nausea, vomiting. Finally, conversion reaction cases of malaria and tuberculosis and pseudo-pregnancies have also been reported. Refer to Box 6.5 for a case study. Naina, 23-year-old, displays all the symptoms of conversion disorder. Box 6.5. Case study, conversion disorder, functional neurological symptom disorder. 23-year-old Naina was brought to the emergency department of a hospital. She reported suddenly passing out for a couple of seconds at work. She stated that she woke up with blurred vision that developed into loss of vision in both eyes. She also reported an inability to stand due to weakness in her left leg. While in the emergency department, the patient described seeing only shadows. She stated that she was generally in good health without significant medical issues or any history of chronic medical conditions or surgeries, which was confirmed by her mother. She had no reported mental health history and no history of stressful childhood experiences, that is, abuse or neglect. Naina's mother reported that her daughter was in a lot of stress since the last couple of years. Her parents got her married right after. 181. Somatic symptoms and related disorders graduation. She wanted to study more, but at that time her parents did not encourage. Her marriage turned out to be extremely stressful, as her husband would often get drunk and become abusive towards her. She left her husband's home 1 year after marriage and came back to live with her parent. After facing significant financial difficulties, Naina finally found a job, but her difficulties were far from over. Her husband sent her a divorce notice and she recently found out that she was pregnant. On physical examination, the patient was alert, awake, and oriented to person, time, and place. On neurological examination, her speech was normal, her pupils were slightly sluggish but reactive, she was able to see light that was shined into her eyes, and she demonstrated a full range of eye movement, but there was no visual acuity to hand motion or finger counts. She had some trouble lifting her left leg off the bed but was able to walk with assistance. All tests came to be normal. Box 6.6. DSM-5 Criteria for Conversion Disorder, Functional Neurological Symptom Disorder, APA, 2013. A. One or more symptoms of altered voluntary motor or sensory function. B. Clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. C. The symptom or deficit is not better explained by another medical or mental disorder. D. The symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants medical evaluation. Specify symptom type. With weakness or paralysis, with abnormal movement, with swallowing symptoms, with speech symptom, with attacks or seizures, with anesthesia or sensory loss, with special sensory symptom, with mixed symptoms. Specify if acute episode, symptoms present for less than 6 months, persistent, symptoms occurring for 6 months or more. Specify if with psychological stressor, specific stressor, without psychological stressor. 6.3.2 Statistics. The lifetime prevalence is not known with certainty, highest estimates as 0.005%, APA, 2013. Women outnumber the diagnoses of conversion symptoms by a ratio of 2 to 1 to 10 to 1. People from low socioeconomic strata are more likely to develop conversion symptoms. Encyclopedia of Mental Disorders, 2015. Conversion symptoms may appear at any time, but most people experience their first symptoms during adolescence or early adult years. Onset is abrupt and typically follows a major stressor. The course of the disorder may either be episodic or chronic. In a subsequent episode, the conversion symptom may be different from the symptoms in the previous episode. Comorbid anxiety and mood disorders are also common. Conversion disorder is at least 2 to 3 times more common in women. 182. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 6.3.3 Causal factors. Although it was earlier believed that there is possibility of genetic influence in the causality of conversion disorder, twin studies did not support this. There is a suggestion of overriding influence of psychosocial factors. Psychoanalytical theory. Freud developed a psychoanalytical model of conversion disorder based on the treatment of the classic case of Anna O. The famous classic case study of Anna O was first discussed in Studies on Hysteria by Freud and Breuer, 1895. He described 4 basic processes in the development of conversion disorder. First, the person experiences an unconscious conflict. Second, since the conflict is unacceptable, the conflict and the resulting anxiety are repressed. Third, the anxiety continues to increase and threatens to become conscious. The person uses the defense mechanisms to convert the conflict into physical symptoms. This leads to reduced anxiety, which is considered to be the primary goal. Fourth, the person receives increased attention and sympathy from loved ones and may also evade certain undesirable tasks. Studies have supported Freud's explanation. Researchers have concluded that individuals with conversion disorder have experienced a traumatic event that must be escaped at all costs. For instance, conversion symptoms such as paralysis of leg were very common in soldiers to avoid the traumatizing combat situations during the World War period without being labeled as a coward. In another study, it was found that most of the patients with conversion disorder had history of traumatic incidents, including history of sexual abuse, recent parental divorce, death, and physical abuse. Support for secondary gain comes from a study that found that adolescents with conversion symptoms rated their mother as overinvolved or overprotected. This suggests that the conversion symptoms may have been strongly attended to and reinforced. Figure 6.3. Psychoanalytical Theory of Conversion Disorder. Unconscious conflict. Repression. The conflict and resulting anxiety is unacceptable, thus repressed. Conversion of symptoms. Primary gain. Anxiety continues to increase and threatens to emerge into consciousness. The person converts it into physical symptoms, thus reducing anxiety. Secondary gains. Increased attention, sympathy, and avoidance of difficult situation, task. 183. Somatic symptoms and related disorders. Sociocultural perspective. Over the past century, there has been an apparent decrease in the incidence of conversion disorder, which suggests a possible role for sociocultural factors. The diagnosis of conversion has declined in Western societies such as US and England, but has remained more common in countries that may place less emphasis on psychologizing distress such as Libya, China, and India. Rates of conversion symptoms are higher in rural regions where medical knowledge is sparse. Growing medical sophistication and increased awareness about the defensive function of a conversion symptom has been attributed to be the reasons behind reduced incidence of conversion disorder. 6.3.4 Treatment. People with conversion disorder respond well to the cognitive behavioral program. An essential element and first in the line of treatment of conversion disorder is to identify the traumatic or stressful life event. The event may be present in real or in the memory of the individual. For instance, in case of Naina, box 6.5, the traumatic incident was being in an abusive relationship with her husband, the impending divorce and discovery of her pregnancy. Second, therapist must educate the family regarding the role of secondary reinforcements such as attention and sympathy. Naina's family must be educated against reinforcing her conversion symptoms through excessive attention and concern. For instance, her mother was advised against restricting Naina's mobility because of her conversion blindness. Instead, she should encourage Naina to carry activities of daily living with support from her family members. Check your progress. 2.1. According to DSM-5, state the diagnostic criteria of conversion disorder. Thank you for listening. Please like and subscribe our channel. 2. Explain the psychoanalytical explanation of conversion disorder. Thank you for listening. Please like and subscribe our channel. 3. How are conversion disorders treated? Thank you for listening. Please like and subscribe our channel. 184. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 6.4 Psychological factors affecting medical condition. The essential feature of this disorder is that an individual has a diagnosed medical condition, example asthma, diabetes, hypertension, etc., that is adversely affected by one or more psychological or behavioral factors. In this condition, the psychological or behavioral factors have a direct influence on the diagnosed medical condition, either by triggering or worsening the medical condition, interfering with treatment, or contributing to death or disability. One example would be a patient with diabetes who is in denial about the need to take medication to control his sugar levels. Another example would be a skin cancer survivor who routinely forgets to apply sunscreen cream to protect himself. 6.5 Factitious disorder. The essential feature of factitious disorder is falsification of medical or psychological signs or symptoms in the absence of obvious external rewards like financial gain or time off work. The motivation for faking of symptoms is not as clear as in cases of malingering. There may be no obvious reason for voluntarily producing the symptoms in oneself, except in some cases it may be done to assume the sick role and receive increased attention. For instance, a woman introduced alkaline chemicals into her eyes, causing corneal burns, before visiting an ophthalmologist. In another case, a man goes to the hospital complaining of abdominal pains, demanding a surgery for removal of his appendix. Preliminary examination revealed no apparent medical reason for the pain. Upon being refused, he goes to another hospital with abscess in his stomach. It was found out that the abscess was self-induced with a kitchen knife. It is essential to establish that the individual is voluntarily producing the symptoms for the diagnosis of factitious disorder. This disorder may extend to other members of the family. An adult may purposely make her child sick, in order to receive attention and pity given to her as the mother of a sick child. This is factitious disorder imposed on another. 6.6 Distinguishing between conversion disorder, factitious disorder, and malingering, faking. Early observations made by Freud noted that people with conversion disorder showed very little fear or anxiety that would be expected in a person with a paralyzed arm or loss of sight. This seeming lack of concern, la belle indifférence, was considered a hallmark of conversion reactions and was included in the diagnostic criteria in previous version of DSM. However, it was removed in DSM-IV since latest researches suggest that only 30 to 50% of people with conversion symptoms showed this lack of concern, and most actually felt quite worried and concerned about their symptoms. APA, 2000. Similarly, another criterion that was present in DSM-IV has been removed in DSM-5. The role of psychological factors was considered an important criterion for diagnosis of conversion disorder. It is common to find emotional, interpersonal conflicts or stressors to precede conversion symptoms. For instance, in case of Naina, box 6.5, abusive relationship with her husband, financial difficulties, juggling of. 185. Somatic symptoms and related disorders. Job with studies and discovery of her pregnancy preceded the onset of her conversion symptom of blindness. However, occurrence of stressful life situations is not considered to be a reliable sign and has been removed as criterion for diagnosis in DSM-5. The presence of a psychological stressor has become a specifier with the diagnosis. The clinician has to specify whether the symptoms are preceded or associated with psychological stressor at the time of diagnosis. People with conversion symptoms can function normally. For instance, people with conversion blindness do not bump into objects, and those with conversion deafness may report they cannot hear anything but may orient their head upon hearing her name. In case of emergencies, a person with conversion paralysis might suddenly get up and run. Some people who experience miraculous cures during religious ceremonies may actually be cases of conversion disorder. It is important to rule out a genuine neurological, medical condition to diagnose conversion disorder. With technological advances, the misdiagnosis rates of conversion disorders have decreased over the years. It might be difficult to distinguish between individuals experiencing conversion symptoms and those malingering or deliberately faking symptoms. Malingerers have clear motivation, such as trying to get out of legal or work difficulties or financial benefits. Relative to those with conversion symptoms, malingerers are fully aware of what they are doing and are clearly trying to manipulate others to gain something desirable. Factitious disorder lies somewhere between malingering and conversion disorder. Although in factitious disorder, the symptoms are under voluntary control, there is no obvious reason for voluntary producing the symptom except to assume the sick role and to get increased attention for being sick. Check your progress 3.1. What are psychological factors affecting medical condition? Why is it considered to be a somatic symptom disorder? Thank you for listening. Please like and subscribe our channel. 2. Define factitious disorder. Thank you for listening. Please like and subscribe our channel. 3. How is factitious disorder different from malingering? Thank you for listening. Please like and subscribe our channel. 186. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 6.7 Summary. Now that we have come to the end of this unit, let us list all the major points that we have already learned. People with somatic symptoms and related disorders are preoccupied with their health and body, and in some case the preoccupation may be so excessive that it becomes maladaptive in their daily lives. Somatic symptom disorder is characterized by 1. More somatic symptoms that are either very distressing and/or result in significant disruption of daily life. Illness. Anxiety disorder is a condition in which physical symptoms are either not experienced at the present time or are very mild. However, the accompanying anxiety focused on the possibility of developing serious diseases is excessive. Illness. Anxiety disorder is a disorder of cognition and perception, with emotional contribution. Individuals' past experiences with illness, both in themselves and others, leads to the development of set of dysfunctional assumptions about the diseases and symptoms that may predispose a person to developing illness. Anxiety disorder. Symptoms in conversion disorder suggest that some kind of neurological disease is affecting the sensory motor systems, but no organic or physical malfunctioning is present. Sigmund Freud popularized the term conversion hysteria, who believed the anxiety resulting from unconscious conflicts was converted into physical symptoms which allowed individuals to release some anxiety without experiencing it. The essential feature of factitious disorder is falsification of medical or psychological signs or symptoms in the absence of obvious external rewards like financial gain or time off work. The motivation for faking of symptoms is not as clear as in cases of malingering. There may be no obvious reason for voluntarily producing the symptoms in oneself, except in some cases it may be done to assume the sick role and receive increased attention. 6.8 Keywords. Somatic symptom disorder. Characterized by 1. More somatic symptoms that are either very distressing and/or result in significant disruption of daily life. Illness. Anxiety disorder. Previously known as hypochondriasis, is a condition in which physical symptoms are either not experienced at the present time or are very mild. However, the accompanying anxiety focused on the possibility of developing serious diseases is excessive. Conversion disorder. Renamed as functional neurological symptom in DSM-5, it refers to symptoms that result in absence of an organic cause. Most conversion symptoms suggest that some kind of neurological disease is affecting the sensory motor systems, but no organic or physical malfunctioning is present. 187. Somatic symptoms and related disorders. Factitious disorder. The essential feature is falsification of medical or psychological signs or symptoms in the absence of obvious external rewards like financial gain or time off work. Malingering. Faking of medical or psychological symptoms so as to get out of legal or work difficulties or get financial benefits. Malingerers are fully aware of what they are doing and are clearly trying to manipulate others to gain something desirable. 6.9 Review questions. 1. People with blank disorders have excessive and maladaptive preoccupation with the functioning of their bodies. 2. Somatic symptoms and related disorders include which of the following? A. Conversion disorder. B. Illness. Anxiety disorder. C. Factitious disorder. D. All of the above. 3. Misinterpretations of bodily sensations play a causal role in the development of disorder. 4. Increased attention and sympathy from loved ones that may reinforce symptoms of conversion disorder are called 5. Refers to deliberate faking of physical symptoms in order to get some clear benefits like financial gain. 6. Individuals with conversion disorder may often display a surprising indifference about their symptoms, especially when the symptoms to most people would be disturbing, example blindness, paralysis. This is sometimes known as a Vive la difference B, quelle difference C, la belle indifference D, KCE c'est la difference. 7. Explain conversion disorder from a psychoanalytic perspective. 8. Differentiate between conversion disorder and factitious disorder. 9. Describe the cognitive behavioral model of illness anxiety disorder. 10. Discuss the treatment of factitious disorder. 6.10 References and further reading American Psychiatric Association Division of Research. 2013. Highlights of changes from DSM-IV to DSM-5, Somatic Symptom and Related Disorders. Focus, 11,